Hello. Hello everyone. A very good evening to all of you. So let me start with a brief introduction about myself. I am Dr. Srinath Chandramani. So today in this new venture of DAMS, that is Medskool, I am going to take you through a very important and short topic of arthritis. So arthritis is a very common topic or a common problem among everybody's. Even whether you are at home, your relative may be suffering from joint pain, your friends are suffering from joint pain, and we also maybe after a sports injury can suffer from joint pain. So in this school today, we are going to learn about arthritis. So first of all, let me tell you that today in this integrated approach to arthritis, I'm going to tell you that how is our teaching in DAMS different from what we would ideally want in the medicine school. So let me tell you and share this story. Each one of you will relate with me that when we all enter medical college, what is our aim? We all want to become the best doctor, right? I tell you this, when we start medical college, we all want to become good doctors. We want to become good clinicians taking care of patients. However, through the journey of medicine school, our priorities and goals change. So most of the average medical student, the first priority becomes to pass the university exam. As we go along, we feel clinical medicine is very far away. First step, let me pass university exam. Second step, let me pass the Neet PG exam. And then finally, after my MD, I'll become a good doctor. Well, by using this goal and in this order, it puts a lot of stress on every medical student out there. Now, just imagine for a moment that in a generation above you, that is your parents, your grandparents, I'm sure that you must have got some of them as doctors. And they were happy and confident to practice even with an MBBS degree. But well, that's not our story, right? How many of us feel confident to start our own practice after MBBS? That's a very small number and that's a very sad number. And that's what we need to change in medicine. How do we change this in medicine? Is that at DAMS, our approach is the exact opposite. I always tell my student that your goal should remain number one is to become a good MBBS doctor. If you do well in learning the clinical aspect, attend your clinical rounds, learn the concepts of medicine, you will definitely pass the university exam and the PG seat will follow. By changing the priorities, what happens? Rather than feeling stressed about the PG seat, I want each one of you to feel confident about getting the PG seat. It's not about the fight for the PG. It's about the fight for becoming a good clinician. If you change that priority, a small change in your mindset will give you lot of rewards. Trust me. So in this small session, I'm going to tell you that what is the core of DAMS coaching. How is it different from what we are experiencing in our day-to-day life? So in DAMS, the teaching of clinical subject, medicine, one of them today I'm taking, is totally conceptual. It is very, very clinical, very crisp, yet comprehensive. At the end of the session, at the end of the class, I want each one of you to go out of the classroom, exit the session feeling like a good doctor of that particular topic. That is my goal. My goal today is not to tell you that you will be able to solve the questions of this topic. No, boss. Questions though you will be able to. But if you can treat the patient, if you can live the topic, that's what we want to achieve in our session today. So let me tell you in this simple topic, integrated approach to arthritis. How are these 4 C's we are going to apply? Arthritis may be a common topic, but what we do? In conceptual means what? We start with basic definitions. Clinical means what we do? We write approach to a case of joint disorder. Crisp means what we do? Classification of inflammatory arthritis. We are going to learn. And comprehensive means we are going to learn points about each disease. So very simple approach. Very simple approach is that we are going to follow one by one each step. At the end of this session, small session, right? We are given only a very small time frame of 1 hour. And arthritis is not only common in practice, but also important for your exam, both university, for Neet PG, and for those of you who will continue as future rheumatologists. Arthritis will be your bread and butter. So we will be covering this topic in these particular steps, one by one, right? So let us start with the first step. So this is a sample of how our teaching will be in medicine in DAMS. First step, we will say that how if a patient of joint pain walks into your OPD, walks into your clinic, how will we approach the patient? So first step is to identify whether the joint pain is arthralgia or is it arthritis. That is very important. The first step, more common, it is going to be just arthralgia. What does arthralgia mean? Arthralgia means when the patient presents with joint pain alone, it is going to be called as arthralgia. That is what is more common in clinical practice. So most patients who present to the OPD with joint pain, they don't need evaluation. They only need palliative treatment with NSAIDs and plenty of reassurance. And that's all you have to do. You don't have to use your brain much. When joint pain is the complaint, all you have to do is prescribe them some painkiller, tell them to take rest, it will get better. But the important topic comes when the patient is a case of arthritis. When do you call it arthritis? When the joint pain is associated with swelling of the joint. When it is associated with swelling of the affected joint, then we are going to call as arthritis. And these are the patient who require further evaluation. So we must understand the steps here. Every joint pain does not need evaluation. Every joint pain we need to understand by history and examination that is it arthralgia or is it arthritis. Let us say it is arthritis. We want to take the patient evaluation forward. So what is the evaluation forward? Every patient of arthritis who has come to a medicine OPD, what I promised you, end of the session, you will become a good MBBS doctor in arthritis. At MBBS level means you are sitting in the medicine OPD or you are doing your internship, and in the orthopedic OPD, you come across a patient with arthritis. What will we do? We want to differentiate what is the type of arthritis. We want to know who should we refer the patient to. More commonly in clinical practice, patient will be a case of degenerative arthritis. When do we say degenerative arthritis or age-related arthritis? Patient is likely to be elderly patient and the symptom typically worsens on activity. Classical example is the osteoarthritis of the knee joint. I'm sure each one of us has got an elderly relative at home who complains of knee joint pain. And during the winter season, the pain is worse and they complain more. So these patients are likely to have symptoms which worsen on activity. Whenever they move the affected joint, there is production of inflammatory mediators which leads to both stiffness and pain in the affected joint. Unfortunately, aging cannot be reversed. I cannot treat it. I can, however, start palliative treatment. I can give them NSAIDs and physiotherapy, and I can consider orthopedic opinion. I can send them for orthopedic opinion to consider the need for joint replacement surgery. I always advise patient that check if the pain is unbearable, restricting your day-to-day activity. You must consult orthopedician and you must consider whether you need or you are a candidate for joint replacement surgery. But that is about orthopedic, not medicine. Today our section is of medicine. So we are dealing with the relatively rare cause but important cause of arthritis. Those are the inflammatory arthritis syndromes. Inflammatory arthritis syndrome typically occur at a younger age group. Typically onset of inflammatory arthritis is relatively younger age group. But the main feature is that they are defined as having severe and prolonged. How much means prolonged? More than 30 minutes. Severe and prolonged. More than 30 minutes of morning stiffness, which gets relieved on activity. That is important to know. Why does this paradoxical response occur? In inflammatory arthritis, inflammatory mediators are produced as a part of the pathology 24/7, whether the joint is active or not. When the affected joint is at rest, the blood flow to the joint is also low, which causes inflammatory mediators to accumulate in the joint. And that is the reason why they wake up with severe and prolonged morning stiffness. But once they start activity, the blood flow increases and washes away the substance P, and hence we say there is paradoxical relief with activity or exercise is the hallmark of inflammatory arthritis. And these are the patient who will require our, that is, rheumatology opinion. So now every medical student is now clear that when they are sitting in the medicine OPD and next time a patient of joint pain comes, at least they will be able to tell कि arthralgia है या arthritis है. Arthralgia होगा NSAIDs and reassurance. Arthritis होगा further evaluation. Degenerative है orthopedic opinion. Inflammatory है rheumatology opinion. So also you know what to ask as an intern, as a resident to the patient with arthritis, which is most important. Because I see कि पेशेंट आ गया, रेसिडेंट ने देखा पेशेंट को, इंटर्न ने देखा पेशेंट को, एंड दे कम टू मी टेलिंग मी सर आर्थराइटिस का पेशेंट है, व्हाट शुड आई डू? नाउ लुक एट दिस क्वेश्चन, आर्थराइटिस का पेशेंट है, व्हाट शुड आई डू? मैं ज्योतिष लगता हूं क्या बॉस? नहीं ना, आई एम नॉट एन एस्ट्रोलॉजर. आर्थराइटिस का ट्रीटमेंट इज अ साइंस, नॉट गेस वर्क. आई नीड मोर इंफॉर्मेशन. So I'm going to ask you, boss, what is the cause of arthritis? बच्चा कहता है सर ऑस्टियोआर्थराइटिस लगता है, रूमेटॉइड आर्थराइटिस लगता है. ये जो लगने की बीमारी है ना मेडिसिन में, इससे आप डरो और इससे दूर रहो, बिकॉज ये ना जल्दी जल्दी फैलता है. तो जब भी कोई कहता है कि मुझे लगता है मेडिसिन में, है ना, उससे दूर भागो. मेडिसिन गेसवर्क नहीं है, यस और नो आंसर है मेरे भाई. So you have to give me reason. You have to give me working diagnosis. I'm not saying that the working diagnosis may be always accurate. Investigations may eventually give a different diagnosis, but that's okay. I'm wanting clinically what is your working diagnosis. And that is very important place to start for each and every one of you medical student. So once you refer patient to rheumatology, now what do we do further? Let us take it forward. तो चलिए, which investigation can you do in the cases of arthritis and what is their significance? So this is a very clinical approach. But actually same thing comes in exam also, that in a patient of arthritis, which test will you prescribe and why? Very simple question. So I am going to prescribe them some serological test and I am going to prescribe them also some radiological test. Some serological test and I am going to prescribe some radiological test in this patient with arthritis. So you tell me that in this patient, which inflammatory markers would you like to send in the patient? Even though patient has got a symptom of morning stiffness, suggesting inflammation in the joint. But we want objective marker of inflammation. For objective marker, we can ask for ESR and CRP. C-reactive protein and ESR are called as the objective markers of inflammation in the given joint. So very good. So every patient comes with arthritis to the OPD. You must look for ESR and CRP. If they are elevated, it confirms that the patient is having a inflammatory arthritis. In all the cases of inflammatory arthritis, which screening antibody would you like to do? We want to undergo rheumatoid factor, that is RA factor. RA factor is the common antibody which is present in the patient with inflammatory arthritis. Screening antibody because it is most commonly present in the patient. But RA factor unfortunately has got many false positive causes. It has got maybe false positive also. And that is why you want to go for the specific antibody in rheumatoid arthritis. The most specific antibody in rheumatoid arthritis is the anti-CCP, also called as the ACPA, in suspected patient with rheumatoid arthritis. It stands for the cyclic citrulinated protein antibody. So every patient who presents with RA factor positive is not enough to confirm that it is rheumatoid arthritis. Along with that, we want to do the specific antibody, that is anti-CCP. But those patients who are RA factor negative, so let us take it here. When the patient is having RA factor positive, then you want to confirm rheumatoid arthritis by asking for anti-CCP. But if the patient is RA factor negative, then what do you do? If the screening antibody is negative, then it is unlikely to be RA, but likely to be a case of SPA, spondyloarthropathies. In spondyloarthropathy, I will go for HLA B27 screening in suspected patient with spondyloarthropathies. Very, very important. So this is the approach. I see many people, when arthritis patient has come to OPD, they will prescribe ESR also, CRP also, RA factor, anti-CCP, HLA B27. क्यों भाई, पैसे पेड़ पे उग रहे हैं क्या आपके? My professor was extremely very ethical. This is called ethics. That patient's money, treat it as your own. Do not spend on tests which are unnecessary. Very important. We must know when to do which test. So in all patients, first I will do ESR, CRP, RA factor. All this together is costing less than 800 rupees. If RA factor comes positive, then to confirm, I can do anti-CCP. Anti-CCP test is costing 1800 rupees. And HLA-B27 can cost more than 2000 rupees. So this is very important. Part of learning is to know the socio-economic value of each test. Is important part of medicine, and it is fun then only when you learn medicine in a practical approach. Along with serological test, you want to do other radiological test also. Which radiological test would you prefer? Obviously, I would prefer to do X-ray of the joint. I would prefer to do X-ray of the joint. I would like to prefer because it is easily available. It is relatively cheap. But please be aware, X-ray of the joint is not most sensitive. May not be sensitive in early cases, and the cases may be missed. So if I want to do the most sensitive test, I would like to go for MRI of the affected joint. MRI of the joint is the best one to detect especially synovitis, especially to pick up synovitis, to pick up marrow edema, and to pick up bone erosions. The most sensitive test remains MRI. Unfortunately, MRI is expensive, and that is why it is not the initial test. So each test, when to do, why to do, what are their limitations, what are their advantages, that is what we want to understand. So every patient, I am going to start with first serological screening and radiological screening. If radiology and serological screening come positive, then I would like to proceed further. I can go for further specific antibody, genetic screening, and I can ask for MRI of the affected joint also. That will be my correct approach. Let us take it further. So I am hoping that all of you have clear concepts about what is arthritis, what is inflammatory arthritis, what are the tests to do for screening, which are specific tests that we want to do in cases of arthritis. Now, let us come to the diagnosis. Now, ये जो point होता है ना, as an MBBS doctor, diagnosis करने में जो gratification है ना, feel good factor होता है. It is very important. Arthritis बोलना, ये तो layman भी बोल देता है, भाई मेरे को arthritis है. As a medical student, as a medical doctor, it gives you a great sense of pride and accomplishment when you diagnose the most probable cause. That impresses the professor even more, who will allow and give more knowledge to you through his experience. So let us take it there. So whenever patient has come from inflammatory arthritis, how will we approach? So this is another important part of difference why a MBBS student needs coaching. Because at MD level, there are standard textbook Harrison, everybody knows. But reading Harrison in totality may be difficult because of the time constraint. I always say, Harrison is the Bible of medicine, no doubt about it. It's like the ultimate book. We want to read it, but it is expansive. Harrison has given 4 different methods to classify and approach inflammatory arthritis. But I always say, Harrison और मेडिकल स्टूडेंट में क्या फर्क होता है? हैरिसन और मेडिकल स्टूडेंट में ये फर्क होता है that Harrison has to write 1 edition every 4 years, but a medical student has to revise the topic 4 times in 1 year. तो बहुत फर्क है ना. हैरिसन के पास बहुत टाइम है यार, उसको लिखने दो 4 क्लासिफिकेशन. हमें क्या चाहिए? 1 integrated practically relevant classification, which we are going to do today. So go step by step. See, I'm here to take you walk through the paces. This is not like a exact point class कि नहीं तोड़ो MCQ. No. Concept, clinical approach. MCQ will follow. इसको ऐसे रखो. So next time you get patient with inflammatory arthritis, क्या करेंगे? First step, count करना. The first step based on the number of joint involved. First step based on the number of joint involved. Just count it, that's all. You don't have to think, use any logic, just count number of joints involved. इसको count कर लो. So there are some students who ask me, sir, if both knee joints are affected, should I count it as 1 or 2? आप ही बताओ बेटा, कैसे बोलना चाहिए, है ना? क्या गेस करना चाहते हो? 1 और 2, है ना? Always 2. अब 2 घुटने हैं ना, आप बोलते हो 2 घुटने हैं, तो यार काउंट भी 2 कर लो यार, है ना? सो कैसा? सो symmetrical. When you say both are affected same, that is symmetrical. One more than the other is asymmetrical. But when you count number of joint, count all of them together as one number. So you have counted. Divide them into the 2 groups. 1. Whether the patient is a case of inflammatory polyarthritis when there is less than 5 joints involved. Matlab 4 or less. And when it is more than equal to 5 joint involvement, then you classify patient as a case of polyarthritis. उसको हटा देते हैं, ठीक है. Polyarthritis पे फोकस करते. Let us focus on polyarthritis. In polyarthritis, further subclassify them into monoarthritis and oligoarthritis. Further subclassify करो. Mono means 1, oligo मतलब 2 to 4 joint. In inflammatory monoarthritis, most common is going to be trauma. Very simple logic है. अगर पेशेंट कहता है, कई बार द पेशेंट डज नॉट नो मेडिसिन ना, और यार बेहतर है कि उसे नहीं आए, गूगल से ना पढ़ के आए, तो सम पेशेंट्स कम टू यू सेइंग दैट डॉक्टर माय एल्बो इज पेनिंग, माय नी इज पेनिंग, 1 joint is affected. But the first step as a medicine person, you will ask them that मार लगा था क्या? Where did you get prior history of injury or trauma? If the patient says हाँ डॉक्टर 10-15 दिन पहले गिर गया था, तब से दुख रहा है, तो क्या बताना है आपको? करेक्ट, आपको बताना है आप गलत ओपीडी में आ गए. ट्रॉमा का ओपीडी ऑर्थो में जाना है. हम अपना दिमाग खर्च नहीं करेंगे. यहां पर you want to exclude trauma and septic arthritis by the clinical history. If the clinical history is present, you refer the patient to orthopedic. Otherwise, patient is our department, a patient of gout. But the differential diagnosis in a polyarthritis, more common is going to be gout. But it can also be a case of pseudo-gout. So both of them together constitute the topic of crystal-induced arthritis. They constitute the topic of crystal-induced arthritis. They are going to constitute. So if the patient is having crystal-induced arthritis, then how will we approach? We want to take it from there. Polyarthritis को फिलहाल हम साइड में रखते हैं. So first classification based on number of joint affected. फिर इसको सब क्लासिफाई करेंगे. एक्शियल डोमिनेंट, अपेंडिकुलर डोमिनेंट. एक्शियल डोमिनेंट मतलब whether the spine involvement is present or not. Spine involvement present or not. We will subclassify. फर्स्ट ग्रुप को आगे बढ़ाते हैं. क्रिस्टल इंड्यूस्ड आर्थराइटिस को आगे बढ़ाते हैं. If the patient is a case of inflammatory polyarthritis, we have got two options in front of us. Inflammatory polyarthritis is there. We have got two options in front of us. More common is going to be gout, and less common, relatively less common, is going to be pseudo gout. Relatively less common is pseudo gout. How to differentiate in the practice and in the question? Same answer, whether patient सामने हो या MCQ के पेपर में हो, आपका अप्रोच सेम रहेगा. You don't waver. So, when will you suspect a polyarthritis in a middle-aged male? A polyarthritis in a middle-aged male who has presented with involvement of great toe or ankle. Middle-aged male who has presented with involvement of great toe or the ankle, I will suspect gout. I will suspect gout. If I suspect gout, what screening test should I do? I will check for elevated serum uric acid level, which is present in majority. But the gold standard test is to demonstrate the deposition of monosodium urate crystal on polarizing microscopy. So what will it show? Polarizing microscopy shows needle-shaped crystal. They are the needle-shaped crystal having strong negative birefringence. The strong negative birefringence is present on polarizing microscopy. That will confirm diagnosis of gout. Diagnosis of gout. In this, long-term treatment obviously is to go for uric acid lowering drugs, that is xanthine oxidase inhibitors, and you want to give uricase enzyme supplement. You want to give uricase enzyme supplement. These are the two treatment options for management of gout. Important, what we are all familiar, allopurinol, xyluric. Xyluric only stops production of uric acid. But if already uric acid is high, we may want to give rasburicase, which can dissolve already produced uric acid also. So that are keywords. So this is the first line, and you can also consider uricase enzyme as an add-on in refractory cases. Add-on in refractory cases. You can check for the same. Other side, when will you say patient is a case of pseudo-gout? When to call it a patient with pseudo-gout? Pseudo-gout in your MCQ will typically be an elderly patient. Will be an typically elderly patient who has presented with involvement of knee, hip or the shoulder joint. Most common is the knee joint, followed by the hip, followed by the shoulder joint. Then you will think automatically of pseudo-gout. In pseudo-gout, what is the paradox? Only 10%, rarely there will be hypercalcemia, because the disease is degenerative, contrasting to your belief. Many times we feel the deposition of calcium pyrophosphate crystal is the pathology. So do majority have hypercalcemia? No. In majority of the patient, disease is degenerative. And polarizing microscopy shows rhomboid shaped crystals. It shows the rhomboid shaped crystals with a mild positive refrigerance. With a mild positive refrigerance on the polarizing microscopy, which will confirm diagnosis of pseudo-gout. Once confirmed, you want to consider palliative treatment with NSAIDs, but majority will require joint replacement surgery in the future. Because once the degeneration has happened, the disease is irreversible and eventually patient will have to undergo joint replacement surgery. So thank you and welcome to Dr. Achin sir, neurologically yours. So there is, DAMS is a family, it's an emotion filled with passionate teachers who want to share everything they have with all of you. We want each one of you to become better than us, to outshine us, because that's the biggest reward for the doctor. So I hope you are all with me. Step by step we are taking. So when patient has presented with inflammatory arthritis and polyarthritis, after excluding trauma, we have to differentiate whether it is gout or whether it is pseudo-gout. That is our aim. Gout versus pseudo-gout. We have completed the topic. Taking us back to polyarthritis. Taking it back to the polyarthritis. So in polyarthritis, how will you approach further? So polyarthritis patient is there. Posse, take it away. When it is a polyarthritis patient, what is our next step? The polyarthritis second step is to check for the dominant joint affected. That's the second classification. First classification done. Number of joint we have counted. Now we know it is polyarthritis. Take this forward. If the polyarthritis is axial dominant, spine is affected. Or whether it is appendicular dominant. We will subclassify them. Axial dominant versus appendicular dominant arthritis. Axial dominant polyarthritis is only one, that is ankylosing spondylitis. Only one is the disease. Differential is there. What are key points for the exam? It is the only male dominant polyarthritis, which has got strongest association with HLA-B27. It most commonly affects the sacroiliac joint. Hence, the young male presents with inflammatory low back pain. Right? It is the only male dominant arthropathy. Female can also have angst, Dr. Anil, but it is the common in male. And important is 70% arthritis is preceded by recurrent unilateral uveitis. So that means extra articular manifestation. Extra articular feature predominates the presentation of the disease. Most of the time you will get the history that patient is referred to you for low back pain, but referred by who? Referred by the ophthalmologist. आपके फ्रेंडली आई डॉक्टर ने भेजा आपके पास कि एक बार जांच करवा लेना कि यूवीआइटिस जो बार बार हो रहा है इसका रीजन क्या है, व्हाट इज द कॉज ऑफ द यूवीआइटिस. दैट इज हाउ रेफरेंस कम्स टू यू. Diagnosis is made, you can proceed to the treatment. Now come to the other side. If the patient is having appendicular dominant, then we have to subclassify them further into two based on the pattern symmetrical small versus asymmetrical large. Come to there is, yes, anterior uveitis, yes. So symmetrical small versus asymmetrical large. So this is our third and fourth classification. Symmetrical versus asymmetrical, small versus large joint classification we want to do. Right? So what are the choices? Based on the pattern. So based on the pattern, symmetrical small, asymmetrical large. If it is symmetrical small, the most common cause of inflammatory polyarthritis is undoubtedly RA. Rheumatoid arthritis is undoubtedly RA. What is important? RA is the only female dominant disease. So only male dominant polyarthritis is angstpon. Only female dominant polyarthritis is RA, while all others are equal in both genders. All others are equal in both genders. The closest differential diagnosis, MCQ, the closest differential diagnosis for rheumatoid arthritis in a patient with symmetrical polyarthritis is psoriatic arthropathy. Is the psoriatic arthropathy is the differential diagnosis. But if the disease is asymmetrical with large joint involvement, asymmetrical with large joint involvement, either it is a case of IBD associated arthropathy or a patient with reactive arthritis. Either IBD associated or it is a case of reactive arthritis which can be seen. So let us take it one by one. That if the patient has come with polyarthritis in the exam, in the practice, first step is to differentiate whether it is a case of RA, which is most likely, or whether it is a patient with SPA, spondyloarthropathy. Spondyloarthropathy is a group of disease we have made in the approach table. So as I said in the class notes, even color coding very important. One of the important ways to make your notes not only attractive, मैं कई बार बोलता हूँ थोड़ा सा कलर डालो, रद्दी पेपर नहीं लगना चाहिए, because after you have written the notes अपने को ही तो पढ़ना है बॉस, है ना, पीछे जाकर लगना तो चाहिए कि थोड़ा सा कलरफुल है, थोड़ा सा प्लीजिंग टू द आई होना चाहिए. सो अगर हम देखेंगे व्हाट आर द SPAs, spondyloarthropathy, SPA include the ankylosing spondylitis 1. It includes IBD associated arthropathy. It includes our reactive arthritis and the psoriatic arthropathy are a part of SP, are a part of spondyloarthropathies. So it is a group of disease. So we want to know how to differentiate between the two, RA versus SPA. So I hope you will share this video with all your medical friends. है ना, first MBBS से लेकर intern तक. किसके लिए? Just to make them aware the beauty of clinical medicine. My only aim is that to indulge your curiosity and your willingness to see the beauty of clinical medicine. Rest, I'm sure all of you have enough IQ to excel in your respective field. So that is the reason why I want all of you to learn how to learn medicine. That's all. Topic तो सब पढ़ाते हैं यार, हर एक डॉक्टर मेरे से अच्छे भी होंगे, ना क्लिनिशियन भी अच्छे होंगे. The important is how the medical student needs to learn medicine. So compare करके देखना. So in the MCQ question or in practice, when polyarthritis comes to you, when will you say patient is RA? RA you will diagnose when patient is RA factor positive, that is seropositive. Unlike SPA, the genetic association is HLA-DR4, DRB1, which does not get transmitted to the next generation. That is why most RA patients are sporadic without family history. Axial involvement is rare. They are all appendicular dominant and their main feature is articular. First line treatment is DMARD. Among the DMARD, if I ask you the question, which is the most potent DMARD in the patient with RA, you will choose methotrexate. But because the patient is a young female and if she gets pregnant, the safest DMARD in pregnancy will be HCQ, hydroxychloroquine. So these are again commonly asked questions, clinically relevant questions. Best answer, methotrexate, but patient is pregnant, choose hydroxychloroquine therapy. When will you say patient is a case of spondyloarthropathy? Spondyloarthropathy is a group, is seronegative. As a group, 4 diseases, it is seronegative. But they can be HLA-B27 positive. Hence, there is strong family history. Axial involvement is relatively common. But important point we highlighted, extra articular symptom predominates the disease. And first line treatment is NSAIDs. All patients of SPA do not need DMARD therapy. Do not need DMARD therapy. You want to give DMARD therapy only if radiological changes present. Only if radiological changes are positive, you want to start patient on DMARD therapy. That is important to know. So just share this video. The awareness of medicine is the main key in this topic. So among the spondyloarthropathy, Angspon property already we have written along with the approach table. So that leaves us 3 topics to go to complete our session. So as I told you, we started with conceptual terms, clinical approach, classification, and salient points of each one of them. Find any question bank. You will see that questions are within these topics. So in short period of time, in short duration, short notes, you are able to cover majority of the points. So one by one, psoriatic arthropathy. Psoriatic arthropathy, as we said, mimics rheumatoid arthritis. Very important. It can mimic rheumatoid arthritis. Then how will I know that it is not RA but it is psoriatic arthropathy? If you read one of the guideline diagnostic criteria is to exclude RA. You have to exclude RA. How to exclude RA? Here the preceding changes are extra-articular, the skin and the nail changes. Most common extra-articular feature. The most common extra-articular feature is going to be oncolysis. Extra-articular feature is going to be oncolysis is going to be present. In 5 to 10%, arthritis may precede. Early DIP involvement is very important. Early DIP involvement differentiates psoriatic from RA, because in RA, DIP involvement is both rare and late, 10 years later. So one answer from your side. What will be the preferred DMARD in a patient with psoriatic arthropathy? Chalo, answer for you. Question for you. Which will be preferred DMARD? If I want to give DMARD in psoriatic arthropathy, which one will I give? Primary problem is not joint. Primary problem is skin and nail. And what is the drug of choice? Methotrexate. In dermatology, you learn for psoriasis, you want to give methotrexate. So for psoriatic arthropathy also, correct answer will be methotrexate. Correct answer. Akash, Swati, very good. That is the correct answer. Now take it to the second one. If it is asymmetrical, large joint involvement, these are the examples of asymmetrical large joint arthritis. The differential diagnosis is the reactive arthritis. Differential diagnosis is the reactive arthritis. We want to differentiate it from. How to differentiate it from reactive arthritis? Here, inflammatory bowel disease are affecting upper limb joints. They are affecting upper limb joint, and they are most commonly preceded by diarrhea. More common with Crohn's disease than ulcerative colitis, and the rare but specific skin manifestation. The rare but specific skin manifestation is the pyoderma gangrenosum. The rare but specific manifestation is the pyoderma gangrenosum. Then you know you are dealing with a case of IBD associated arthritis. So again, I have left one column for you. What will be the preferred DMARD in a patient with IBD associated arthritis? What will be the preferred DMARD? You tell me. Again, in spondyloarthropathy, main focus is bowel. A DMARD which will control diarrhea also is sulfasalazine, which will control diarrhea also, reduces the bowel disease, controls the diarrhea also. That will be the preferred DMARD in this patient. Very good. You want to give sulfasalazine. That is our correct answer. And the last one is the reactive arthritis, but it is the most common of SPA. Most common cause of SPA. Almost 70% of spondyloarthropathies are reactive arthritis. Most common cause of the spondyloarthropathy is the reactive arthritis. Here also they are asymmetrical, but they predominantly affect lower limb joints. So compared to the IBD, here they present with knee and ankle involvement. The knee and the ankle joint involvement is very typical of reactive arthritis. Since reactive means post-infective, most commonly they are preceded by which infection? Chlamydia. Original Retter's syndrome was discussed with Neisseria gonococci. But after penicillin has come, gonococcus is gone. Single dose can eradicate. So gonococcal, most common cause of non-gonococcal urethritis. Non-gonococcal urethritis is chlamydia. So that has become number one risk factor for our reactive arthritis. Also other infections, salmonella, that is enteric fever in our country, and of course don't forget chikungunya. There are few states in our country which are endemic for chikungunya. I am sure everybody knows. After that there is reactive arthritis. But in reactive arthritis, the rare but specific skin manifestation, is the keratoderma blennorrhagica, which are keratotic plaques present on the palms and on the soles. You can mark answer as reactive arthritis. Since the reactive arthritis are post-infective, you want a DMARD which is immunomodulator also, which can take care of inflammation after the infection. And what is that drug? Come on, last question for this session. Which will be the preferred DMARD? Will be hydroxychloroquine. Hydroxychloroquine, which probably we tried during COVID pandemic also, was to reduce the risk of cytokine storm, reduce the risk of post-infective inflammation. That is called as immunomodulator action. So if you just read these many slides, trust me, not only will you feel confident to evaluate a patient of arthritis, refer the patient to the appropriate specialist, start them with first line management, and once you know that, you will 100% pass the university exam and also crack the Neet PG entrance. So this is the approach we want to have in DAMS. It is compact, comprehensive, but conceptual, clinical is the key to success, right? So if you like the video, thank you very much. You can hit the like button like all YouTubers. So it is, as they say, it is no longer education that the people seek. It is edutainment. So everybody, of course, a teacher's job is to make the topic colorful, interactive, practical, relevant, interesting, all that masala to chahiye. But of course, I'm not the best at that. I'm the plain old professor who gives you content, but with a clinical touch. So you can log into eMedicos for any more lectures. You can go through the courses available that suits you, and you can use the discount code which will help you do better. So share it with maximum number of medical students, okay, in your entire class. Just tell them to have a look. It's not very big. It's just a sample that we understand. So those of you who want PDF of this session, you can all email to me, okay. So if you can share your feedback along with your requirement of the PDF, I will be happy to share them on the email, because on the YouTube I cannot upload, so we can manage them. Definitely, as we get along in med school, we will be covering more and more topics from different subjects. You can put it in your also comment box that which topic would you like. I will definitely consider. We will all work together, and success is most important. So please relax, okay? Please relax. Panic is your worst enemy on the day of the exam. Panic is worst enemy, because in MCQ based examination, please trust me, one of the option has to be correct. So the answer is in front of you. Panic करेंगे तो गलत आंसर मार्क करके आएंगे, एंड वहीं पर हम मार्क खाते हैं, रैंक हमारा कम होता है. सो थोड़ा सा रिलैक्सेशन के लिए चाहिए कॉन्फिडेंस, कॉन्फिडेंस के लिए चाहिए कंटेंट, कंटेंट के लिए चाहिए कंसेप्ट. बिकॉज मेमोरी में इतना जगह है नहीं कि हम सारा कुछ मेमोरी में भर सके. हमें कंसेप्ट चाहिए, क्लिनिकल अप्रोच चाहिए, एंड सक्सेस विल बी योर्स. ऑल द वेरी बेस्ट. चलो, थैंक यू सो मच. बाय बाय.